record that. Could I share my screen, please?
You can start sharing your screen, but I think we can wait for a couple of minutes more so that everybody joins in, and then I'll introduce you to the professionals, and then we may start the presentation.
Of course, absolutely. No problem.
Yeah. Okay, so in the meantime, I can start the live stream, Meenakshi?
Yes, I think you can do that.
Okay, perfect.
Yavish, Aprajita says that she can't join from the link. Can you send it to her again?
Yeah, sure, ma'am. Sunanda is joining, ma'am.
Okay, fine. Good.
Good work.
All right. I think we should start on time to end it on time. Hello, very good afternoon to you. Good morning to Monica. Professor Monica, this is Dr. Meenakshi this side. Welcome to the forum. I hope you can hear me.
I can hear you as well.
Yes, I can hear you.
Thank you for joining. We are honored to have you with us. Thank you very much.
I'm so happy that I can now, because I don't have this
just take
hospital
a call
appointment.
and yeah.
So I get out of it for the micro and the picture. Yeah. Okay.
So I think more or less all the participants have joined. Maybe a couple of them would be joining eventually very, very soon. So as to begin with today's session, I think the professionals are familiar with, no, sorry. Okay, fine. I hope everybody can see me and can hear me. So we are about to begin the session, and we have with us today Professor Monica, who was there with us when we had an offline session on 2 days. So it was she who primarily delivered the lectures, and we had a healthy discussion also with her. And after that, the today's session is by an expert, Jean McHale. Welcome to the forum, Jean. And I'll just introduce you briefly our participants for the day. Professor Jean McHale researches and writes in the area of health law and healthcare law. She is the director of Centre for Health Law, Science and Policy at Birmingham Law School. She has written several books, chapters, and research articles. Her recent books include The Regulation of Cosmetic Procedures, Legal, Ethical, and Practical Challenges, and also the European Health Law Themes and Implications, Handbook on Complementary and Alternative Medicines. Professor McHale is currently the principal investigator on the ESRC COVID-19 Rapid Response Grant, Removing Rights from the Vulnerable, the Impact of COVID-19 Social Care Easements. She has also the PI on the UK Changing Europe Initiative Grant, Health Law Outside the EU, Immediate, Intermediate and Long-Term Impacts. She was also a co-grant holder on the National Institute for Health Research grant named Understanding Employee Whistleblowing in Healthcare, and the AHRC Research Network grant, The Changing Demands of Beauty. So as you can see, she's a highly accomplished expert in her area, and we are really delighted and honored to have her with us for today's session. So the session will begin, it will be a close to, I don't know, I mean, maybe approximately 90-minute session, and then we can take up your questions at the end of it. Please write your questions in the chat box so that we can discuss. So over to you, Jean. I hope you can start with your presentation for the day.
Thank you very much. And I'm delighted to be with you, although it's virtual today, and to contribute to your ongoing program. What I'm going to focus on today is look at some of the issues in relation to the European Union as a system of multi-level governance in health, and also as well set some of these developments in the context of the EU's response to COVID-19. Now, the slides are just starting to freeze. 1 second, let me just do this now. Yeah. So in this session, we're going to look at the EU as a multi-level system of governance. We're going to look at the role of the EU in relation to public health and some of the consequent impacts on the health systems of member states and the EU's response to COVID-19 and what might be the legacy of that response of the EU. Now, European Union health law itself is something which, in academic terms, is a relatively new subject. And it's something which has evolved in particular, really, over the last couple of decades. And in many ways, of course, to understand really how it works, you have to understand, of course, the fact that this is not one single document, one single codified structure, elucidating out the various principles of health law across the EU. In many ways, it is still very much a matter of evolution. And I do stress that evolution rather than revolution, a gradual development, though something which has been triggered at various stages by a range of other factors. And that those multiple contributing factors may be at times external factors, things such as developments of scandals that have pushed reform in the area, in areas such as pharmaceuticals, etc. Also, too, again, the sort of the broader evolution of the approach that's been taken by the European Commission itself to things, and also the push with member states in taking forward policy and legal development actually in this particular area. Now, in terms of the evolution of it, in many ways, if you go right the way back, European health law can be seen rooted in principles going back to things such as, the common agricultural policy and the common market itself. In terms of looking at the ways in which the methods of governance themselves have been implemented, this has evolved over time. If you look, for example, at some of the older EU directives, these older measures can be seen in terms of much more sort of questions of harmonisation, trying to be prescriptive, aligning standards very definitively. And this can be very much seen in terms of the approach in relation to early pharmaceutical regulation. There are also other policy approaches to that. So from the mid-1980s, the movement towards what was called at that time the new approach, harmonisation, giving more flexibility regarding implementations. And as Tammy Harvey and I wrote in our book in 2015, that this sort of new approach to internal market law was essentially distinguishing between what was essential to harmonise and what could be said to be left to mutual recognition of national regulations and standards. And you see this as a sort of attention essentially around the development of policy. How much you centralise, you coordinate and you unify, or how much is a matter to be left to member states, recognising their diversity of regulatory approaches, norms, etc., at member state level. And this can be seen in relation to a whole range of issues. For example, the area of clinical trials and pharmaceuticals is another area I know you will be looking at. In terms of the questions of the issue of consent to treatment, consent to involvement in a trial, what consent norms mean in different member states can be different, driven by the domestic law in those specific member states. Now, as well as that too, this also can be seen in terms of, the coordination through those development of, regulations and policy, and also though through soft coordination. And this has been developed through this idea of the open method of coordination. The idea of, as defined here from the EU itself, intergovernmental policy making that doesn't result in binding EU legislative measures. It does not require the countries of the European Union to introduce or amend their laws, and also to, apologies, that financial incentives should have been on the next line. Financial incentives are there as well. These are things that can facilitate development, encourage working together between member states, essentially, triggering policy change through the facilitation of those sort of approaches. And really from the mid-2000s, you see the sort of pull-push in terms of policy development in relation to the EU, what you leave at member state level, or what the extent to which you move towards greater harmonisation. And there is indeed some evidence of that, again, from the mid-2000s onwards. Now, also, of course, in looking at the evolution of health law and governance, you have to see this in terms of questions of fundamental principles. And these operate, of course, through provisions set down in the EU treaties that we'll come on to look at in a moment as well. And of course, in addition to that, specific documentation, very important documentation, such as the EU Charter of Fundamental Rights and Freedoms. And this charter itself places fundamental rights front and centre in the development of EU health policy from that period in the early 2000s. And this is, again, developed further in relation to this idea of common values and principles in EU health systems, adopted in 2006. Now, of course, human rights are nothing new for those EU member states who are signatories anyway under the Council of Europe Convention, the European Convention of Human Rights. What the EU Charter of Fundamental Rights and Freedoms does, though, is it provides a much more modern declaration of rights, not simply a traditional civil and political declaration of rights, but something which is much more involved, recognizing much more economic and social and cultural rights, a much broader human rights statement. Now, in terms of how EU health law and governance has evolved, this has to be seen in terms, of course, of the relationship between the various EU bodies themselves in developing law and policy, the lead taken by, indeed, the EU Commission in relation to this area, and, of course, as well, the steer that comes from the EU presidency in relation to policy evolution. And we'll come on to see how that has impacted over the last few years, in fact, when we come and unpick some of these issues later on in this presentation. There is also, too, that question of the relationship between the EU and the member states. And this, of course, is vitally important, not least recognising the importance of subsidiarity, and that member states themselves have the ability to develop their own policies in the area of health in terms of going forward. It also means that in terms of developing health policy in this area, there's need for considerable, at times, very considerable negotiation between the various parties who have claims and their own views as to where EU policy itself should go forward. Now, as I said, the use of softer forms of governance as well do play, as I said, a part here. And I've just mentioned before that question of financial incentives. And as I said, these sort of things really can't be underestimated in terms of their importance. Now, in many ways, I mean, Tammy Harvey and I, in our book, we pulled out what we saw to be a range of, really the themes in relation to EU health law and governance. And I just want to, go through these here with you. Now, the first of these is that of risk. Writ large, really, through the development of the EU law and policy, is this question of the regulation of risky activities. You see this, for example, from the EU's engagement in pharmaceuticals in response to, of course, the thalidomide tragedy. You see it in other areas as well, and we'll come on to this in relation to blood and tissue and cells, but particularly blood safety questions. That the regulation there triggered, again, by scandal in terms of blood contamination scandals across various European Union countries. Also, too, recognising the need to anticipate risk as it will arise and developing proportionate policy, as we've seen more recently in terms of EU regulation in relation to medical devices, where there's been a wholesale reform of that. And I know you will be looking at that with others on this programme. The other thing too, as I said, is that question of rights, and we pick that up just with the Charter of Fundamental Rights. That this is both seen as fundamental to the EU, recognising both civil and political rights, rights to life, rights to liberty, and rights to privacy, but also broader rights, such as rights in relation to healthcare, as in the context of Article 35 of the EU Charter. The other thing too, in terms of themes that strongly come out of EU health law and governance, is around the question of consumerism and the patient as a consumer who is able to purchase services in the health market. And as part of the free movement principles, the patient being able to travel indeed to another member state to obtain treatment as well, that comes under this. There's also as well the question of solidarity, and as I said, I put there the definition, the quote from our book on that. That really, this idea of respecting the solidarity of member states, and also as part of that, that may lead to cross-subsidisation with groups within states. It may mean cross-subsidisation through taxation or social insurance. It may mean as well the idea in terms of the obligation to contribute to the state. And finally, of course, the question of competition. Ensuring a fair market and thus enabling, competition to be effectively regulated and considered. Now, of course, that again goes beyond the scope of today's presentation. Now, in terms of the evolution of health policy, and as I said, this is what I think is quite interesting, of the take that's placed on this really by the Commission, and notably by the President of the Commission. And I drew upon here Van Ellie Brooks and Mary Guy's recent piece in Health, Economics, Policy and the Law. That during the presidency of President Juncker, that health policy in the EU at the end of the 2010s was much more really tightly delimited. And that here really, although, yes, there is a commissioner for health, that their role was precisely described and was limited, doing various things such as crisis preparedness, genetically modified organisms, pharmaceuticals, health systems performance, and at that time was their response to Ebola. And that if it wasn't under that specific agenda or linking to his own specific projects, then it really wasn't something that was really able to be taken forward. And this also shows some of the challenges of trying to roll out health law and health policy at EU level. The EU treaty does have, the various EU treaties have various provisions that are particularly important here. And health is something that's mainstreamed, considered to be fundamentally important at EU level. And this comes from, again, provisions in the treaty. I mean, of course, notably Article 9. The Union itself is to take into account requirements linked to the promotion of, obviously, high levels of employment, social protection, fight against social exclusion, high level of education and training, and critically, the protection of human health. Now, that should be there linked through all those policies and activities. And also, too, as well, specifically, the emphasis on, under Article 6.8, the need for a high level of human health protection to improving public health, preventing physical and mental illness and disease, and obviating the sources of danger to physical and mental health. This is therefore to be implemented in relation to all EU policies and activities. Now, note, of course, this is complementing national policies, so the wording here is important. It's the combination with what is happening with member states. And of course, it's looking at their sort of pull-push, therefore, of what's actually happening at member state level. So it's not entirely overtaking what member states are doing. But at the same time, it involves action, including promoting research, including information, including monitoring and early warning of the combating of serious cross-border threats to health. And this again comes back to our idea of risk. The EU itself is fundamentally concerned with combating risks to health. And you see that notably, of course, in relation to questions around communicable diseases. Again, drugs-related health damage is right up there as a sort of issue the EU itself is concerned fundamentally with. And 168 as well deals with the question of cooperation. It encourages cooperation between member states and, if necessary, lending support Now, again, and this is, of course, the interesting thing, encouraging cooperation between member states to improve the complementarity of their health services in cross-border areas. Because, of course, people crossing borders is facilitated through free movement. So the EU is not mandating a particular approach to the delivery of a health service, but it is at the same time facilitating links, facilitating actions, facilitating those questions of cooperation and complementarity where needed. Now, again, of course, they can coordinate and develop these sorts of policies. And as again, 168 is saying too here, about establishing guidelines, best practice, elements for monitoring as well. And also too, Article 1683 is really interesting because here it's talking about the need to foster cooperation with third countries and competent international organisations in the sphere of public health. So again, written to the treaty is this idea of engagement beyond the boundaries of the EU, engaging with other countries, fostering cooperation about that, recognising that critically, and as COVID sadly has demonstrated all too well, disease is no respecter of borders. Now, 1684, again, is a really important provision. And here, this is indicating that the Parliament and the Council shall contribute to the achievement of the objectives in this article through adopting, in order to meet common safety concerns, measures in these three areas. So there is specific jurisdiction given to the EU Parliament and Council to operate in relation to these three particular areas. Now, all these areas can be seen linked to questions of risk. They can also, of course, be linked to questions of markets as well. And for our purposes, we want to look particularly at subsection A and subsection C. Here, first of all, we're looking at measures setting high standards of quality and safety of organs and substances of human origin, blood and blood derivatives. This is about recognising those real risks of disease transmission in this area. It's indicated the blood contamination scandals, etc., and taking action. Also, too, as well, the need for high standard quality and safety for medicinal products and devices. Again, recognising, these are risky things. So this is the treaty giving specific powers for the EU to step in relation to this and place measures in place to address common safety concerns. Now, again, the need for questions around incentive measures are built into Article 168 subsection 5, and this relates to cross-border health threats and also in relation to things concerning tobacco and the abuse of alcohol. The EU has had a long interest in both those areas themselves, and we'll come on to look specifically at tobacco shortly. But noting that it's excluding harmonisation of the laws and regulations of member states. So it's a fine line here. The drive is not to harmonise, it's to facilitate measures in the area. On the other hand, of course, the EU's development in the area may by itself then actually bring together what actually those member states do on the relation to those particular issues. But you can see the tensions around this, and they, in Article 168 subsection 7. And here again, they're saying, look, the Union is respecting the responsibilities of the states, the definition of their health policy, and for the organisation and delivery of health services and of medical care. And so again, it's for the member states to manage their own health services, it's saying, managing the medical care, and again, the allocation of resources. So the questions around, again, blood and tissue issues, they relate to questions of safety, but they're not relating questions around donation or medical use of organs and blood. So separate laws apply in relation to transplantation, as opposed to the broader safety questions. And of course, there are alignments there. So, but on the other hand, you see some EU countries operate on the basis of opt-out systems and others do not, for instance. So it's recognising that diversity in approach on what, of course, again, are very controversial ethical issues. Now, in terms of, again, the application of public health at EU level, so the EU has come in both in relation to communicable diseases in this area and also non-communicable diseases. And an example of that is the question of tobacco regulation. Now, I want to look at this really as a sort of case study. And this has historically been a most significant cause of death in the EU. And there has been a very, very long history of the EU's involvement in this area, going right the way back. And this, of course, relates to the question of risk. Because in smoking, of course, you're dealing with risks to the individual and their health, who are the consumers, direct consumers. But of course, again, there is the other broader problem for, again, inverted commas, passive smoking, secondary, individuals who may end up developing cancer as a result of being exposed to tobacco smoke consumed by somebody, tobacco consumed by somebody else. So there's sort of risks in terms of the direct health to the individual. And also, of course, the broader community costs of this as well and harms, because this, again, takes up a large amount of health resources. If individuals suffer smoking-related ill health, and this can have, therefore, broader costs to the community in terms of delivery of healthcare itself, and broader implications, of course, in other areas such as employment, etc. But there've always been tensions here, and this, of course, gets down to the question of autonomy, the individual's ability to make bad choices, to make or unwise choices about their own lives, even though the risk of undertaking those choices is that their health could be severely damaged, and indeed they could die as a result. And that this can also be seen in terms of those broader tensions around the questions of fundamental rights and questions around the right to private life, and how that fundamental human right can be seen in terms of protection for autonomy. But the right to private life, and again, certainly at ECHR level, has never been utilised to fundamentally mean that you have a right to smoke in all situations and so on, and impacting on others. And of course, rights to privacy in terms of health have to be seen and are seen as a balancing consideration. These are qualified rights, where you're looking at the balance between an individual's claim rights and the rights and freedoms of others in these sort of situations. And this doesn't mean, of course, that these issues don't remain fundamentally controversial. So the regulation of this area has been, a matter of very, very heated debate over very, very many years. And indeed, the most recent directive in 2014 was the subject of, that sort of considerable degrees of controversy. And also, too, of course, you're not simply dealing with the questions of the rights or claims of the individual. You're also as well dealing with, behind this, industry, who of course has vested interest in supporting smoking related behaviour as part of their business model. And therefore this particular directive is a directive that was subject to a lot of lobbying when it was being considered. Now, finally, the directive as it was produced provides quite considerable regulation of this area, and it regulates in different ways, really. And in some ways, these are typical EU-type regulatory strategies in the area of health. First of all, it's about regulating the particular danger caused by the product itself. So hence the regulation around emissions of tar, nicotine, carbon monoxide, as a result of the use of smoking products. It's also as well addressing the consumption of tobacco. And this is through various methods. So, of course, the directive is not stopping people smoking. What it's doing is it's putting in place effectively inhibitors, trying to discourage people from doing so. So there are very specific requirements stating warnings that have to be included on cigarette packaging. And and also as well, these include pictorial warnings as well of the consequences of smoking. Dimensions are defined and so on. So the precise labels, the wording that needs to be on there, again, is defined. So the packaging, etc. itself is controlled. And that's also linked to the idea of discouraging consumption. So the idea of having very small sort of lipstick style packaging with a couple of cigarettes or so was banned under the directive. Again, it's trying to make things less suave, less attractive. It's making it seem that this is something that people shouldn't be doing. We're not stopping you, but we're putting things in place to indicate that society itself is not seeing this as an appropriate way going forward. And one of also the targets as well of the directive and the concerns about this, as indeed with, of course, other areas of, course, EU health policy, is the concern about protecting young people. And also recognising that from an industry perspective, you know, the young people can be, if they are encouraged to participate in smoking, whether through e-cigarettes or otherwise in the early days, that then provides a captive market potentially for later on. And so, you know, therefore the directive regulates the use of additives, flavourings, and so on, what can and what can't be done. It also, of course, does regulate e-cigarettes, because this, by, you know, the early 2010s, was starting to become a big issue. And of course, tobacco companies themselves were taking on e-cigarette firms themselves, and this was being seen as an effective business opportunity going forward, recognising that overall the numbers of people taking up standard cigarette smoking was going down. So that you've got regulations specifically then, you know, addressing that, which is included in this particular directive. Again, you know, advertising very tightly regulated for these purposes. And also as well, the idea of, and this again is another, again, sort of EU classic model of where things are going. And we see this with other areas too, you know, tracking and tracing systems for product control, recognising that trying to stop effectively, you know, bootleg, dealing with packaging which has content itself that could be harmful. So requirements of proper tracking and tracing systems, and with unique identifiers on packs, so that illicit dealing in that sense as well could be addressed. So it's about constraining the market, regulating the market, in providing information, discouraging things, but stopping short of banning. Okay, so let's look at a second case study in relation to public health, and this is the question of blood and organ tissue safety. And as I said, this is something which was driven by scandal and the infection of haemophiliacs with HIV in the 1980s and the 1990s across various EU member states. Now, this then led to, and of course, this is why it's written into, again, 168 of the treaty. This can be seen now today in terms of the regulation of these products at individual member state level. And there are, you know, the three notable directives in relation to this. Now, what is the case is that essentially, really, again, these are standard, almost identikit directives in the way in which actually they approach and regulate. They all take the approach of there needs to be minimum quality and safety standards. The need for establishments that are using the products to be accredited, designated, authorised or licensed as appropriate, that they are going to be subject to inspection by a competent authority of the member states. So individual member states need a competent authority to undertake this role. And the competent authority themselves, again, has oversight, therefore, of procurement, of testing, of the processing, preservation, storage and distribution of blood and tissue and cells. So it's about recognising that those organisations who are handling, blood, tissue, etc., are operating subject to these standards, and they are obviously liable to be inspected and accredited in relation to this. Now, also too, these directives, again, provide various things in terms of clinical selection of donors. They require provisions in relation to consent and provision of information. And those operate alongside the consent provisions, as said, at member state level. And as I said a few minutes ago, what the EU law doesn't do is it doesn't tread on, effectively what are ethical and, other judgments made by member states as to how precisely the process of informed consent operates at that member state level exactly. But what they do is they do require certain things in terms of information to be required. So they don't say, for example, at what age a child has competency to consent, for instance. But they do require information in relation to, they do require, for example, that X amount of information is given and so on. Now, as I said, it's also requirements specifically about quality standards and, again, fundamentally about risk, and this is so that the risk concerns underpin these directives themselves are also linked to the fact that there are platforms in existence for alerting people, alerting authorities in relation to risks which have arisen in relation to these materials. And so these rapid alert systems are in place, computerized systems, and that these provide information about if there's a defective batch, if there's a problem, in relation to disease transmission, if there has been illegal or fraudulent activities. These computerized systems will enable these sorts of information to be shared across EU level and EU member states rapidly, so that problems can be identified and neutralised and not replicated in other member states unaware of what was going on in a particular member state. So effective as well, it's about solidarity too as well. It's cooperation and working together for the whole. Now, as I said, it's the idea of tracking and tracing systems here. So this is the idea, we've seen this in relation to tobacco products and this is also as well applicable in the context of tissue and cells. As of the directive in 2015, the idea that there is a unique identifier and what is a single European code which facilitates this, so that you can track where the products have been. And again, this enables you in terms of, so if there is a risk, if there is a problem, you can track this back. It also regulates export of materials as well. And also too common across the directives as well is this principle of non-commodification, something which itself is contained in the EU Charter of Fundamental Rights. It's interesting. I mean, one of the things, of course, about EU law is that it doesn't stand still. This is an example of this, of course, at the moment. I mean, the Tissue and Cells Directive is under review, and they are looking to what was included and what wasn't included originally, and existing technical requirements as well. One of the things as well that the latest review has been pulling up is about things around reproductive materials as well, and follow-up of donors, questions of adverse reaction as well in this area. And of course, this also reflects the fact of the incredible growth of the use of reproductive technologies across member states over the last couple of decades. This is no longer an sort of a wonderful, exceptional area of medicine. It's something which is far, far more routine. And so it's recognizing the need to ensure, again, consistency of protection as well. They've also raised questions too about ensuring independence of regulators going forward, and that's likely to be something then picked up, eventually in terms of the reform of the directive. Okay, so disease transmission is something, again, which of course, as we said, is really, a major concern. We've seen it through tissue and cells directives in this situation. And as we've said, disease is no respecter of borders. The EU itself has a specific agency, which the European Centre for Disease Prevention and Control, which was established following the SARS outbreak back in 2003. And the regulation itself has established this centre. Now, this provides a considerable degree of oversight and transmission of information in relation to communicable diseases at EU level. The operation of the agency, though, has, over time, there's been concerns expressed. Not that the idea that the agency itself is a problem, but how effective it is able to operate. And concerns have been expressed that its staffing could be greater, its budget could be larger, and perhaps at times it could be better placed to respond. Now, its mission itself, of course, is that of identifying and assessing emerging threats and, the ability to act on its own initiative. And of course, was able to communicate on this, of course, during the COVID pandemic itself. It has a role in relation to, its main task, searching for, evaluating, disseminating data, providing scientific opinions, providing training. And also as well, so it's a data collection exercise, and a very important one. It's also an information transmission body. So it's providing timely information to Commission, member states, agencies, and also to other international organisations. So again, this is the idea of the external face of the EU in terms of developing policy. It's recognising that, cooperation, acting beyond borders, recognising that things like public health is a global health question in this way. It also coordinates networking bodies in this mission, its mission 2, and it's about, again, exchanging information. It's not just providing information, but it's exchanging information and best practices and facilitating development as well. Now, and I'll come on to some of the role of this, the links to this in relation to COVID and where this may be going shortly, when we look at some of the very recent developments by Ursula von der Leyen and the Commission more generally in going forward to look at how things should be developed as we emerge from the COVID pandemic. I use the word emerge cautiously because, of course, the impact of the pandemic is still, of course, being felt across the world as I speak. I now also want to look at, so that you've got areas then that in the EU treaties where fundamental principles in relation to respect for health are inbuilt. There are also as well, in terms of the way in which the EU impacts on health and health policy, the EU's engagement with free movement and the ability to access services in another member state. And this relates to Article 6 of the Treaty of the Functioning of the European Union, whereby, that restrictions on the freedom to provide services in the Union shall be prohibited in respect of nationals of member states, who are established in the member states of the other member state than for which the person for whom the services were intended. So individuals themselves can and do have a fundamental right of free movement. And the fundamental right of free movement is facilitated through a range of rules in which have an applicability in relation to healthcare, through the rules concerning social security at EU level. And these include reimbursement for provisions of healthcare services. So there are provisions in Regulation 883/2004, so enabling EU citizens who are working in other member states, or if they've retired to another EU member state, perhaps, for example, because they think that living in the south of Spain rather than perhaps one of the northern EU states is going to be better in terms of weather and other helping their health as they're getting older or whatever, or the question of emergency healthcare in other member states. So the idea of reciprocity. So if somebody has, is on holiday in Berlin, and they are normally resident in Paris, they're able to claim the emergency healthcare for that and be reimbursed for so doing. But also, what the law in this area does is enable individuals to travel to another member state to actually obtain treatment and then have that reimbursed. Now, in terms of emergency treatment or treatment which is necessary on medical grounds during their stay, this is operated through what's known as the European Health Insurance Card in practice. And so somebody, if somebody's involved in an accident and shows their European Health Insurance Card, that will cover the vast majority of the cost of their treatment in that situation. It does only cover, though, that's necessary on medical grounds. It doesn't cover absolutely everything. And also, too, it does tend to vary a bit between member states. So some member states require degrees of financial contribution to various aspects of treatment and care anyway for their own citizens. And if they do that, then over and above the social security system, so in effect, certain other upfront costs or cost for paying for their treatment in relation to care while they're in hospital, those sort of costs that effectively top-up charges would be still required to be paid. So it is, though, essentially reciprocity itself. And it is the sort of thing, though, that does work, particularly in those EU health systems where there are insurance schemes, perhaps rather more than where there's more of an NHS type system. So less perhaps the Italian and Spanish type system in quite the same way, as much perhaps as some of the others. But also what's really interesting is that the regulation enables people to actually go to another member state and to obtain treatment in that member state and then come back to their home member state and have that treatment covered and the cost of that treatment covered. Now that is something which is something that's written into Regulation 883/2004. And an insured person can go to another member state and receive the benefits that would be provided in your own member state, and in that, as long as it could not be given within a time limit medically justifiable, take into account the current state of health and probable course of illness. So if somebody was on a long waiting list in their own member state, they could travel to another EU member state and effectively bypass that waiting list in a particular situation. Now, they would be required normally to ask for permission to go ahead and obtain that treatment in that way. And there's been a whole series of cases on this, which we don't have time to obviously go through today in terms of it. But right from the days of the case of Cole, where the Luxembourg social insurance scheme refused to fund orthodontic care of somebody in Germany, and that was held contrary to free movement. This sort of reimbursement has been recognised. It applies to hospital care. It doesn't just apply to, in effect, primary first stage care, though that will still need prior authorisation. There was considerable controversy, in fact, of the extent to which this would apply to national health service systems, In a case which concerned the UK, while the UK was still a member of the EU, the Watts litigation, the European Court of Justice confirmed that their article, what was at that time Article 49, applied in that situation, so that somebody themselves could, as in that case, bypass existing waiting restrictions by going to another EU member state and then claim back reimbursement for that when they came home. But of course, these sort of things, this idea of being able to do this type of thing is very interesting, because this is an example of potentially how EU law and policy and EU law can impact on member states in a way in which some people in those member states may find very, very problematic. Now, here, you know, on the one hand, you could say, well, and Gareth Davis in his article on the Watts case was saying, well, look, you know, the waiting lists are only legally problematic at the time so long it could not be clinically justified, and it was medically indefensible here. So you could say, well, in this case, and she'd been waiting, you know, quite a while for treatment, she desperately needed treatment, that therefore it was justifiable to enable somebody to go abroad. So you can certainly see it in terms of the interest of patients and empowering them. On the other hand, though, does this mean that individual patients who know that the legal provisions are available could simply bypass the restrictions at national law level, and go ahead and do this? That they could simply, you know, say, well, look, you know, in this situation, you know, I know about this, I can bypass this restriction, and effectively shoot themselves up a bit higher on the, you know, on the priority list than they would have been otherwise if they had to wait on a waiting list that the member state itself was actually operating. Montgomery's argument here was that, you know, it would benefit those skilled at using markets, both patients and providers. It'll do so at the expense of distributed justice and undermine the NHS. But again, you could substitute from the NHS any other member state's health system in that, you know, that somebody could effectively get round it. So you could say that EU law here was undermining the priorities at national level. So though what the EU law explicitly states, it's not taking over national health systems, that it could undermine the operation of that by enabling people to exercise free movement rights and seek services in another member state. Now, Article 883/2004 has to also today be seen in the light of the EU Patients' Rights Directive. And so the language of this directive and the terms of the directive are really interesting, because this again is linked to that question of the extent to which individual member states themselves, you know, prioritization of resources, operation of individual health systems can be undermined by EU law. So what this Patient Rights Directive does is it replaces what were some of the original cases under free movement in relation to this original regulation. And it addresses questions of prior real authorization and individuals who want to travel for treatment to another member state. Now, individuals can have got there are certain provisions in terms of reimbursements. There's a slight difference in the provisions as to how it works. Normally, in the case of 883/2004, it's prior authorization, then the member state will pay. So individuals will seek authorization to go ahead to another member state and receive treatment. In the case of the directive, it works in terms of, you know, reimbursement. Now, in the case of 883/2004, in fact, reimbursement could work retrospectively because somebody might have still, as in the Watts case, gone ahead anyway, and then disputed it and then claimed it back. In the case of the directive, the patient actually does pay up front and then claims reimbursement. Now, the directive is framed in terms of patient rights, not simply rights to seek access to medical services. And I think that the terms of that are actually quite interesting. In terms of healthcare, this directive applies to a whole range of broad services, including prescriptions, as well as provisions of medicinal products. And it does exclude various things, though. So it excludes things such as long-term care, it excludes organ transplantation. That's a matter that's left specifically to member states. And we've seen the sensitivity of that, for example, in terms of the provisions in relation to the Organ Transplants Directive. And it also excludes vaccination programs. Now, this, of course, is relevant in relation to COVID, because so individuals couldn't move from one member state to another member state if they saw that another member state was running their vaccination programs slightly differently in relation to a particular age group, for example. That vaccinations themselves are a matter for implementation by the member state. So you're not going to be able to access any of these services in that way. Long-term care, you see, was considered to be fundamental. And also this relates to, again, some of the real broad problems, the fact that although across member states there is, detailed regulations in relation to healthcare, social care and longer term care is one of those much broader problems going forward in terms of how these should be actually addressed at member state level. Now, what's really interesting actually is that this directive as well links to questions of informed consent. So providers have had to provide information about the treatment options available, including quality and safety of healthcare, so that these information have to be made publicly available. So one of the consequences of the directive is that the member states have to lodge what treatments are available in their member state. So this could be potentially quite a useful bit of information for citizens of those states who wouldn't necessarily realise all the specific treatment options which were made available in an individual member state, in fact, as well. So that, as I said, is the sort of thing that has to be, made available under the directive. And this, therefore, as I said, can be seen not just for treatment tourists, but also for member state citizens. And it has been suggested, really, that could this then give greater pressure on states to provide publication of information concerning quality indicators? I mean, that's the aspiration. It doesn't really appear to have worked like that, though, indeed, over the last decade, so since the directives come into force. However, other things have come out of this here that will and are being taken forward. I mean, one example of this is Article 5D, and we'll come on to this in terms of some more recent developments later. The idea of facilitating patient choice of access to medical records, or the right to access them electronically. And this also can be seen in terms of questions of privacy, and the EU itself is concerned very much with the privacy of data through the and has very specific, data protection regulation in this area. But at the same time, the questions of access as well are seen as fundamentally important here. The idea of being able to port your medical records and indeed port prescriptions as well. Now, although an individual can travel for treatment and claim reimbursement of it, it's not absolute. And this also reflects, again, some of those concerns when this directive was being debated, raised by member states as to how far patient mobility could undermine choice at member state level. And so this comes out very strongly in relation to Article 8.2 of the directive. And it makes these decisions subject to planning requirements relating to, again, the objective of ensuring access to balanced and high quality treatment, avoiding costs, avoiding waste. And so prior authorization, therefore, is needed if treatment itself involves overnight hospital accommodation, if it involves costly infrastructure, if it involves treatments that may present a particular risk to the patient or population. So if you're talking about a very, very innovative treatment, or something that might have broader considerations longer term to other people's health. I mean, a really useful example of that would be, say, xenotransplantation, for example. Then that would be a ground, though actually that's not, because transplant normally isn't sanctioned, but something that involves the animal-human transmission of viruses would be one. Or if it's something provided by a healthcare provider that could raise serious and significant concerns about the quality of the care. So that this is because one of the concerns about the idea of people being able to go to another country to obtain treatment faster, etc., and then claim back reimbursement was what happens if things go wrong. I mean, one sees that, of course, if people have private sector treatment and they're not claiming us back via a state insurance scheme, for example. And of course, you can't control that in the same way. But this concern here, the idea that people could travel lawfully and claim the money back lawfully, but there may be major concerns about the quality and safety of healthcare in another EU member state, which you wouldn't necessarily want them to have the operation there, and then they could come back and something, because of the poor quality, the individual member state, their home member state, may end up having to pay the bill for this, a very expensive bill. And so the balance around that was addressed by the need of prior authorization, could and will apply in a situation of if there are any specific concerns about treatment. Again, requirement for authorization there too. Now, again, when treatment is allowed, again, this is reflected in the provisions of 883/2004, the regulations. So the aim is still that treatment should be in an individual's own member state, unless, based on, the objective medical assessment, that you can't provide it within that sort of time limit. Looking at the patient's condition, the degree of the patient's pain and suffering, and so on. Now, authorization can be refused. And again, this relates to one, if there's a patient, that everything's about patient safety here. So you can refuse to reimburse this, to refuse the authorization to go. If somebody is going to be exposed with a certainty to an unacceptable patient safety risk, or if the public will be exposed to that safety hazard. So if it was likely that somebody, that would have arisen in the context of COVID, for example, where if somebody, if say the infection levels for COVID had been particularly high in a border another state, and in the particular member state in question, the person wanted to travel from, if the COVID levels actually been very, very low, then you might have said, well, there's a risk of the person going to that hospital contracting COVID. It may have then been asymptomatic, they could have brought it back. That potentially would have been an example, but that's just one of a whole series of conditions, of course, that could be the case. Ebola being another, of course, example. And so, but also, again, you can refuse authorization if there is serious and specific concerns about quality of care and patient safety. And again, or if you could anyway, it's justifiable to still wait for treatment in the country in question. Now, this idea of then, so that potentially EU law here can impact on delivery of healthcare in member state by enabling people to bypass standard state rules. But in practice, has that really happened? Well, the answer is not. It's only been comparatively limited over time, and that really essentially that, again, as the Commission reported in 2015, very small numbers of people have applied for a prior authorization itself. And that, again, European Patients Forum in 2016, that overall it was pretty steady, but it wasn't going up across member states. And in some ways, some of this obviously was reflective of the experience of that particular member state in terms of waiting lists or other issues. So that was an issue, for example, with the Republic of Ireland. But it hasn't, and critically, shown significant growth or reduction in that period of time for reporting. Now, this is important, actually, and this is reflected in other ways. So where you get patients moving, it tends to be across, literally hopping over the border type thing. So France to Spain, you've got a border. France to Germany, you've got a border. And you're not as much talking about people, and you're talking about traveling really, really big distances as well. So that the actual undermining of state autonomy in terms of resources is comparatively limited as well. And And, you know, that yes, greater numbers of information was available, but again, concern about information, for example, people with disabilities. So the numbers overall had increased, but only up to a point. And there's the question really, well, why is that the case? And this may be also down to perhaps not as surprising as you might think. Because quite often, of course, you know, that is the issue of proximity. You know, it's one thing being if you're able to literally drive across a border to another country, which is literally next door. If you're in Luxembourg, for example, it's one thing. But again, if you're in the middle of another much larger EU member state, then you have to have a very extensive journey and you're not feeling very well. Well, you know, again, this comes down to the fact of, well, will people travel? It also comes down to the fact of availability of treatment abroad. It only applies, of course, to elective procedures. Also, some people too may be put off by the fact that they do not speak the language in question of the country where that treatment is available, and not want to travel because they feel awkward about not being able to as effectively communicate, potentially in a hospital. There's a question of whether the difference in medical cultures across jurisdictions, whether that's impacted. We don't know really on this. But also, again, I said, if somebody's very ill, then are they physically able to get on a plane? Are they going to physically able to be in a car for a very long period of time, or so on, as well? So, you know, you can see it in terms, on the one hand, the EU law itself is a positive for a patient. It's facilitating patients' choice, accessing faster treatment, etc. But some of the arguments is, does it benefit all patients? We get back to, say, Montgomery and other arguments around here too. Or is it simply privileging those people who are wealthier, who are relatively healthy, but say in pain, for example, wanting a hip replacement, who are educated, the knowledge to make these choices? So is EU law here itself not acting, a sense, uniformly in terms of individual rights, but privileging a certain group? And also, of course, there's concerns about adverse impact on the member state in question too, as well. Something else just to flag up though of the directives is this movement towards the establishment of European reference networks and centres of excellence, facilitating and supporting medical centres of excellence to work together across member states. And again, this comes also with the use of EU funding too, and enabling people to work virtually, extending information, you know, transferring information and so on. You know, I mean, literally that thing about, you know, sharing knowledge. I mean, medicine is a global language, as you will, people in this room, or this virtual room, will know only too well. And so that these can be seen, this particular measure in Article 12 can be seen as facilitating that sort of global, you know, again, dialogue across the EU, the sharing information about patients with rare diseases, unusual conditions and whatever. So that the directive isn't all about, you know, actually moving for treatment. It's also about, again, facilitating these sorts of things. Now, in terms of how EU law has impacted on the undertaking at member state level of treatment things too, just again, I mean, a couple of other notable examples. The idea of the mutual recognition of professional qualification, the idea of having recognised minimum state training standards which are operational. And so that this then facilitates individuals being able to travel across the EU and work in another member state by the respect given for the medical training in those member states in question. And recognising minimal training periods, for example. And these also include two provisions in relation to safety alert processes, enabling information to be transferred over in relation to individuals who may have had professional malpractice findings made against them. Also, as well as that, too, in the employment situation, again, you know, limiting and constraining the number of working hours of healthcare professionals too, through the use of the Working Time Directive in the context of employment law. Now, I just want to come on to, in this final session of the presentation, really, seeing how these various levels of the EU engaging with health law and health governance can be seen in the light of the impact and the legacy, indeed, of the COVID pandemic for the EU itself. Now, in many ways, the response here itself can be seen in both in terms of the immediate response, but then really what are the longer term impacts for health law and policy going forward? What was very, very clear in the early stages of the pandemic were the sort of the fault lines in existing structures. The ECDC operated, but again, its limits in terms of its scope, its limits in terms of resourcing, certainly became evident at the start. There were also broader questions as well of the resilience of member states' health systems to address fundamentally the COVID pandemic. And also too, concerns about failure to learn from past pandemic planning and so on. And also too, the question of the impact of austerity on member states and on their health systems, and what this really, really means in practice. Now, although solidarity is such an important value at EU level, nonetheless, what was rather stark was the lack of solidarity in the early stages and the problematic coordination of the use of healthcare resources at the start. The inability really to rush to support other member states, and obviously Italy was particularly at the sharp end right at the start of this, and rather the retreating behind the borders. And I think it's probably fair to say that this is something which shook the EU, and I think it probably shook people's perceptions of the EU. That suddenly that this was seen to be closing borders, closing boundaries. Now, things improved over time, and when the EU got its act together, it did get its act together much more in terms of financial support, in coordination. It was also recognised too that COVID was a threat to free movement, and it was. And of course, member states can indeed, restrict access through their borders. They're entitled to do that indeed, in health emergencies and so on. But then this is also linked to what we're going to come on to see as well in relation to the development of the idea of vaccine passports. The idea of enabling people to still have free movement, but to travel and to reduce the prospect of disease transmission to another member state. There's also a broader thing, sorry, I want to come on to, which is the question of development of health policy going forward here. Now, as I said, so I mean, Giordano and Triviano Salza's quote here is notable, really. That there was really that sort of lack of coordination at EU level was very, very sharp. And the public health response wasn't possible because the emergency structures had not been set up. And it wasn't seen to be a public good at the start, as they argue, that there had been a strategic stockpile, which had been approved, but, it hadn't been implemented. So it was only, really implemented after the WHO declared a global pandemic in 2020. They knew that there needed to be strategic stockpiles well over a year earlier. It was there, it was approved, and nothing had been done. Nothing had been done until you're in a situation where it's pretty well almost too late. And then they were desperately running to try and catch up. And so that these two bits of solidarity, as I said, the distribution of medical support, the closure of borders, were real issues. The limitations of existing structures, for example, the ECDC. So, I mean, they did move and they did try, so I said, within their limitations. And they did issue recommendations on things like social distancing, on things such as contact tracing. So this is going right, they were back into March 2020. So it wasn't that they weren't doing things. But of course, there was only so much they could do. So they were able to make recommendations, but these were non-binding. And things varied across member states in terms of how this was managed, in terms of how social distancing was managed, in terms of how mask wearing eventually was introduced and managed, and so on. There was a considerable disparity. Now, of course, the digital certificates, though, could be seen in here as, well, is this something in relation to safeguarding free movement and and indeed ultimately in promoting trust. And those tensions, as I said at the start of the pandemic, and the impact of border closures. So this wasn't simply about patients moving to receive treatment in other member states. There was, of course, and this, of course, is a global issue. We saw the impact on airlines, we saw the impact on industry generally, and industry itself is still, in the process of recovering from this, the question of, shortages of materials and so on, and of course, tourism. And these things, again, critical to member states, and particularly critical to some as well. Now, of course, as we said, free movement can be limited under public health grounds under the treaty itself. So the EU is moving towards things such as strategy for sustainable tourism, recognising, that how to address these types of things. So tensions between effectively health, respecting those, and then recognising as well that health also equals wealth, and that the damage to economies, of course, could have longer term, health impacts as well in the population, in terms of people's livelihoods, jobs, and more generally, of course, the impact of the economy if people are laid off and so on, that lose their jobs. The idea of moving towards data protection, to digital certificates flowed from this. And this also can be seen across the backdrop to, of course, the idea that this would need the question of storing information. And of course, the EU is rooted in protection for privacy. As we saw, the Charter of Fundamental Rights incorporates both privacy and personal data. And also the idea of the data protection and regulation as well. So this is all right the way through the core of EU health policy. And so that the EU itself was trying to essentially get a balance between recognising the idea of free movement and putting things in place, enabling people to provide information about their health status, their COVID health status, and making that available while at the same time protecting privacy of individuals in relation to that health information. And then how you ultimately balance that. So Regulation 2021-953 aim to try and really address that question, to try and align free movement, respecting proportionality and non-discrimination with high levels of public health protection. Now, the idea was to have a free certificate that could be issued in digital or paper format, and would be issued by national authorities in their language and also in English, and valid across all EU member states. So the idea of consistency of approach as to which EU COVID health outcomes would be recognised to enable somebody to travel. And so this wasn't just about vaccinations. It also includes somebody who has a negative, because of course some people are not able to have a vaccination on health grounds, of course. So it also relates to individuals who had a negative test certificate or recovered from COVID. And the member states do have to accept the vaccines which are approved by the European Medicines Agency, which recognised for a period of 9 months after the administration of the last dose of the primary vaccines. And also in some situations too, they can issue COVID certificates to people who've been given EU-approved vaccines outside the EU. Now, it relates to negative test results. So those were agreed under the regulation for standard periods for those tests. And that also, again, would enable somebody to be exempted from possible quarantine requirements. But I'll come on to that in a minute. Other restrictions couldn't still be imposed. Recovery from infections also included in this situation, though it doesn't apply to antibody tests as well, actually. Now, the key features, therefore, is that the certificate operates via a QR code, essential information is there, and it's stored in the central database in the country itself. So the QR code is scanned, but the certificates holder data does not pass via this gateway. That's not needed for the digital signature. So they enabled them to protect privacy and things at the same time. And information is included that's limited. Again, it's that limited, absolutely limited necessary. It is not a person's whole health records. And so again, as I said, the process is checking simply the validity and authenticity in the situation. Now, it's the idea of trust, essentially. It's a trust framework for verifying certificates. The data that's processed, the minimal possible as well. and it's only for the purposes of the pandemic, only data that's necessary. And again, there has to be a detailed list provided as to who will be the data controller, who will process this information in the individual member states in question. Now, there was always concern about data security, you see, in the prospect of forgery of this, and those concerns do still remain. Now, however, that does not mean that member states cannot still impose restrictions. The idea of the data, the idea of the COVID certificate is that it's enabling people to move. It's enabling that information to be available so that member states have the assurance when somebody's being admitted that they are vaccinated or whatever, so reducing the risk on their population. But a member state can put new restrictions in place, and they can act fast if they want to. Now, and really fast. So although the regulation is saying that the Commission and member states should be informed, or the member states informed at least 48 hours before, here, it's where possible. So there's degrees of discretion in this. They could, put sudden restriction in, but they should inform of the reasons for restriction, the scope of the restriction, and how long that restriction is going to happen. And of course, to be fair, this is the sort of information that should then also be passed to the European Centre for Disease Control as well. Because if you have a specific sudden major outbreak, say in a border state or whatever, on the near border of a state, that's the sort of thing that's important for the state. It's important for other people as well, generally to know about, and for the EU generally to know about. So the aim here is streamlining consistency. It's not a vaccine passport as such, it's other things. The security still is an issue. Now, it was due to apply originally for 12 months, but they are now calling for it to apply to June 2023. And also they do recognise certificates from certain other non-EU countries too. Now, and of course, this relates more broadly to the EU's facilitating transfer of health information. I'll come to now in the final section. So member states can limit movement on public health grounds, but if you've got a COVID certificate, then you can travel unless the member state has imposed other restrictions. And that those should only be imposed if they're necessary and proportionate in a particular situation. Now, of course, the question really is COVID though changing the way in which we look at questions around health and the EU? I mean, we've seen this in relation to the restrictions and the fact that these are due to be temporary and so on. There's a more general question, though. I mean, last summer there was a debate. Our own Secretary of State for Transport raised this about whether things like double vaccinations are going to be general, whether vaccinations will be required to enter, or other things, or indeed other health identifiers. I mean, obviously, vaccination of things like yellow fever were required historically anyway under the international health regulations, but general vaccinations weren't. And this, I think it's an interesting question, really, in terms of health policy of what will happen longer term, or whether we will just simply go back to before. But there are broader questions for the EU in terms of what this means for health law and health governance at member state level. And so this can be linked to first of all, I mean, you can see the debates around this prior to COVID, of course, in the state of health of the EU in 2019, there were concerns about vaccine hesitancy then, and how it could be addressed. And those concerns, of course, remain on the table today. There were concerns about, poor data quality and the questions of universal health coverage. There were concerns about how disadvantaged groups were impacted in relation to multiple barriers in accessing healthcare. And of course, as we've seen, and we've seen this, of course, right the way across the world, questions of socioeconomic disadvantage and ethnicity have been linked to notable adverse consequences from COVID. Now, the EU itself in 2019 were talking about the need for resilience of health systems and responding to shocks and crises. But of course, as we saw with COVID, resilience was something which was sorely lacking in those early months of 2020. And that Ursula von der Leyen, as President of the European Commission, has recognised the need for the European Union to move forward in this area and in terms of developing further multi-level health law and governance in the area, that the fact, as she said in speaking in October 2020, we cannot wait for the end of the pandemic to prepare for the future. We build the foundations of a stronger European health union in which the countries will work together to detect, prepare and respond collectively. And this is operating now at various levels. So that essentially in some ways, I mean, you might say that the pandemic is now turbocharging some developments in EU health policy that are coming now on stream. The first is in relation to, I mean, there's the EU Health Work Programme to fund actions in the area of disease prevention, crisis preparedness, health systems, and digital issues too, across member states. So this is now ongoing. In addition to that as well, this movement towards a European health union. And the language, the shift in language here, I think is really significant. The idea of, again, is said here, of EU member countries preparing and responding to health crises and available, informative and innovative, working together to improve prevention and treatment and aftercare for diseases such as cancer, protecting citizens and equipping the EU to better address future pandemics and improve resilience. So what essentially they're trying to do here is address some of the sorts of things that they'd identified as being a problem back in 2019 and which weren't in place when the pandemic hit. Now, as part of this, the idea of a new authority, so that it was recognised there wasn't enough in place to address preparedness for health emergencies. So that, you know, a new authority here with the task of addressing threat assessments, the task of addressing also promoting advanced research and development of medical measures and counter-related technologies, the task of addressing challenges in the marketplace, and also failures and boosting strategy and autonomy here. So you're dealing with both detection, promotion of research, and as well identifying the way in which technology in the future can and should evolve to facilitate this. You've then also got the question as well of again, medical countermeasures. So this goes back to those recommendations in 2019 that weren't acted on until it's too late. The need for things like stockpiling and public procurement to be in place, not to be caught, effect sleeping as they were at the time. Strengthening as well knowledge and skills, so it's improving capacity at member state level and their ability as well to respond. Now, again, this new body here is distinct from the European Centre for Disease Control and is distinct from the European Medicines Agency. And that because, again, as the quotes from the statement from Brussels stated, that the EDC has a specific mandate, but it hasn't a general mandate regards health threats generally, nor indeed it didn't have any powers in relation to procuring things, developing things, producing them. And it couldn't be criticised for doing stuff it never had the ability to do in the first place, of course. The European Medicines Agency itself, again, has regulatory measures. And of course it was involved from early on in relation to, review of vaccine safety and so on, but it didn't have the mandate in other areas. And again, of course, doesn't have roles in relation to procurement, stockpiling, etc. So this new authority has got the ability to come in this sort of way. So again, it's strengthening health security coordination. It's addressing vulnerability in planning here now. And the planning as well it's also and this I think is important, it's contributing to reinforcing the global health emergency preparedness and response architecture. The EU is recognising here, that this is a global question. This is not something, as well as we've seen with COVID, that we really are we're not all in it together in the sense that we don't all nations do not respond to it from the same level of financial support for health systems, the same levels of equality, same broader questions of health determinants. So we are unequal anyway in that respect. But nonetheless, of course, disease is still, as we've, again, and I say this, I said this several times, but is, of course, no respecter of borders. So that you've got the situation of the EDC, ECDC will have enhanced roles here, and this will be built into their role. enhanced capacity, enhanced roles in relation to reference laboratories and so on. So these things will be there. The Medicines Agency role will be enhanced in these areas to monitor shortages, providing advice, coordinating studies and coordinating clinical trials. So it's boosting existing bodies, and it's also working with this new body too. But the European Health Union is not simply about emergencies. And what's really interesting is that COVID is here being used as a catalyst for evolution of multi-level EU health law and policy going forward in this area, in other ways. So, I mean, cancer has been always something which, of course, the EU has addressed over a long time, and we've seen this in the context of tobacco. And this is seen again in terms of driving forward cancer strategies over the last 2 years. And again, this comes from, you know, the risk factors. We've seen some of these already. There will be new initiatives in terms of screening, new initiatives in relation to cancer diagnostic and treatment networks. And again, about quality of life as well for those people who've survived cancer too. And as this room will know, it's not simply about just, you know, saving life as such. That's vitally important. It's also about living life, your life after that, with the implications of the impact of that cancer on somebody's health going forward, which at times, of course, can be devastating, or may indeed be devastating in a whole range of ways. So also, too, something else has come out of this, of where Ursula von der Leyen's initiatives are going in relation to the Commission. European health data space, this idea of empowerment, digital access to and controlling health data. So this is linked again to some of those sorts of things that we saw in the Patient Rights Directive, the idea of facilitating, again, health records across, but also too, again, in terms of support in relation to the regulations of devices and other things as well. So that the effective use of health data is being seen as fundamental, both in terms of empowering patients for them obtaining information in relation to safety of devices and other things. We've seen this in terms of medical devices, which we'll be looking at separately, in relation to the provisions of information specifically for people in terms of information cards, if they've had an implanted medical device, for example. So it's following a sort of trajectory, but it's also as well about making data available for research. So it's both for patients and for research as well, because it's recognizing that secondary use of data in this is a powerful, very powerful scientific tool. And so that it's building on this, there will be an EU health digital infrastructure. And so this is building where originally, of course, the Patient Rights Directive came in, this idea of you know, porting prescriptions across to another member state when you travel, recognizing e-prescriptions and patient summaries too being available, because the concern about if people go abroad and they're treated in another member state and their medical records are not available in the same way, then that's risky too. So this is facilitating better and safer care of people travel. So where are we? When I go back to the start, essentially, that there's still not one, if you like, single document of EU health law and policy. It's drawing upon a myriad of sources, treaty, cases, policy documents, soft law. COVID itself is here and it's evolving, but there's an interesting question, I think, of the level to which it's evolving, because COVID has led to, again, a reassessment of where we were. And this gets down to, as I said, that sort of commitment here. We've seen the difference of the Juncker years and where von der Leyen appears to be going. This appears to be, at first sight, though, of course, you know, it really does remain to be seen, something that's much more innovative, really. Now, the question then is, COVID raises challenges, and we've seen this, of course, but this leads to this greater focus on health security in the EU, and that's picked up through the new agencies and trying to empower existing agencies too. But of course, things are still ongoing, and we've seen this, of course, and as you'll see in other areas, in terms of other modules, in terms of regulation of clinical trials, implementation of law in that area going forward, and also, of course, as we've seen in relation to tissue. So fundamentally here really is it the case, as I said, I do think these words, European Health Union, are yes, they're symbolic, but they're really, yeah, it's a really important, it's a very, very powerful signal that's come from Ursula von der Leyen on this. And I think there's a question of, it's really too early to tell absolutely as to whether, but it may do, whether this European Health Union is a really very decisive policy shift going forward, and perhaps changes some of the way in which we look at EU health law policy and governance. Thanks very much.
Thank you, Professor Jean. Thank you for the in-depth overview you gave on the health governance in the EU, and by touching upon various aspects, I think you touched upon various things which are recent as well as lingering for a long time. And you used your case studies, they were very interesting, and I am very sure the participants would have learned and found it very, very interesting also. And you talked about, I like the way you talked that, you know, European Union is going to make a European Health Union now in the coming time. So there's a lot of coordination going on, a lot of solidarity required, and taking from COVID-19 a lot of learning, and thereby, you know, making it as a HERA, that is Health Emergency Preparedness and Responsiveness Authority. That's great. So I think India can learn a lot from European Union health policies, and we have something similar with you, but then there are other things coming up. So moving on, if you permit, we have a few question answers. We can go to Q&A session now.
Of course.
Okay. All right. So I'll just very quickly ask you one question, which I have for you is based upon like you talked about the organ, tissue, and cell donation, right? So in that case, what is the legislation on surrogacy in European Union? Do we have a legislation related to it?
No, there isn't. Surrogacy is a matter. Surrogacy itself is a matter for member states. And so there are different laws and different policies and different approaches that apply to the member state level. And this again is because the whole question of surrogacy itself is it's a family law issue. So that in terms of the detailed regulation of that, in the same way actually as, so the regulation of reproductive technologies is and always has been a matter for the individual member states. And this, again, as with the issues of abortion, for that matter too, and one of the policy reasons for that, of course, is that because this is not something that fits neatly within one of the jurisdictional heads of the EU to act anyway. And of course, is an area too where ultimately getting agreement on would be challenging, given different ethical approaches, different moral issues in relation to the aspects of it. So but it's a very important question, of course, yes. So the things around donor safety, and so where the Tissue and Cells Directive, for example, they're looking at reform, are questions about information of donors. Say about health issues to do with donors, tracking, those sorts of things. So it's about a specific safety question, as opposed to regulating the fundamentals of the technology.
All right, thank you very much. Another question from one of the participants is, so far, what has been the most complex legal aspect in Europeanization of health?
Oh dear. Oh, that is such a tricky one, actually, really. Because
point of view, maybe.
No, I honestly don't think there's a single thing. There are several things which have been very tricky at different times for different reasons, really. I mean, the tobacco one I gave as an example, because it, again, the negotiations around that, the controversy, the role of industry there, the lobbying was absolutely massive. And it took them a very, very long time to get that measure through. But at the same time, if you look at other areas as well, I mean, things such as the recent reforms in relation to medical devices, I mean, that was underway for a very long time. That followed, again, some of the controversies over the PIP implant scandal. And it led to originally looking at the broader questions of oversight of safety in relation to implants and other things. And this meant that ultimately they realized anyway that the devices directives were outdated in relation to evolution of science and technology in the area. So it wasn't just scandals, it was recognizing the practicalities. But again, one of the big issues around that was whether medical devices regulation should be brought under the umbrella of the European Medicines Agency. And there were some suggestions as to whether it should, because that broader question of having an overarching safety agency that would then regulate it as you regulate medicines. And that ultimately, of course, was rejected. But it was on the table at the time. And that was, again, really controversial. I mean, another really good example of things that, again, took a very long time in the discussions was about the Patient Rights Directive and the amount of, and the impact of, again, patient mobility, the concerns, there really are, and there still remains the concerns about people going to other member states. They're harmed as a result of getting treatment in another member state and they come back. What are the consequences? One of the debates around there was actually about whether, ultimately, about should there be greater alignment about the compensation systems in member states. And if that, of course, that goes into an area of EU law that's normally not regulated. Again, the question of liability. If there's harm caused, but it did relate to those practical issues that if somebody travels elsewhere and they're harmed, they come back and they end up having to emergency treatment in their home member state. There's extra cost for that. So that plus the extent to which it would undermine member states by people being able to travel. Now, we've seen, of course, that actually the figures around that are not massive. But nonetheless, it's still controversial. The fact it still was there. And they were recognising through the treaty and the free movement principles it was still going to have to be. And they were trying to manage it. So, I mean, those are examples. And in terms of big areas of law that were eventually changed, and each time they were protracted, it led to negotiations in some ways that you expected, because you're dealing with a whole range of member states, all justifiably entitled to have expressed their views on things, and recognizing it's about cooperation, it's about compromise. And how to have effective coordination going forward, So, I mean, those are three notable examples. There are more, but so that one, sadly, is I wouldn't like to rank the relevant levels of disruption, because I think it would depend on who you talk to as to how they would view it.
I'm sure the long innings you have had in EU law formation, and going by your experience, you will have many more challenges to share with us. But I think that reasonably explains, it answers the question very well. So the next question is related to this only. Like you talked about smoking, you presented a case study on that, how it affects the various European Union members. So somebody wants to know that what makes these directives, especially related to smoking, more successful in some of the member states than the others?
Yes. Well, I think there's an interesting question really of the idea of the directives and also linked to broader policy developments such as the WHO's Framework Convention on Tobacco Control, which again, of course, because again it is a global issue very much, is that the directive itself has to be seen as a compromise measure. It's moving towards limiting, constraining use, but there has to be also the degrees of buy-in at individual state level, and some states are more restrictive than others in terms of the questions of banning smoking in public places, controls in that sort of way. The EU measure can only go so far because it's a compromise measure as a result of the negotiations over where you get to. the other things in relation to that then have to be taken up at state level. And about cultural change. Some of the cultural change things take a while. So it's like the restrictions on, labeling on cigarette packets. It's about the restriction, the questions on advertising. It's about trying to change the culture. What the directive doesn't do is it doesn't ban things in that sense. It doesn't stop people smoking. It doesn't ban things in public places in the same way. And so that's where perhaps, it's a question of over time things changing. You have to have member state buy-in. And so that may be seen as a failure, perhaps, or it may be seen as something that simply in some nations it takes longer than others.
Correct. Okay, fine, thank you. Then there's another one related to COVID-19, which I think has been reasonably explained by you reasonably well. You devoted quite a bit of time to that COVID-19 situation. So it was like, whether the COVID-19 will hamper or favor the EU competencies in the field of health. So you had very nicely explained how initially there was lack of coordination, and then there was a lot of coordination, financial as well as a lot of solidarity in tackling the crisis and the challenge. So I think this question has been answered. This was asked in the beginning of your today's session. So you have answered that already. So the final question I have got for you is by one of the participants here is that, as you talked about informed consents for various procedures, so what are the ethical and legal issues that you face in maintaining the continuity of informed consents?
Yes, well, this is the extent to which the EU law only goes so far. So, for example, information provisions are included in various of the EU documents. So the regulations on clinical trials, for example, the provisions in relation to, well, actually pharmaceuticals has always been a good example on that, because the idea that you have to provide information in medicine packets and provide an information sheet was something which, because I remember in this country talking to some pharmacists who'd been working when that was originally introduced, while we were still, well, of course the UK is no longer sadly a member of the EU, but when we were members of the EU. And one of the things that at the time was that they were having patients then coming to them after they'd read the patient information sheets and coming back to them saying, well, yes, but what about this? What about this? They were starting to engage with information which routinely otherwise they wouldn't have been given prior to the EU coming in on this. So that the idea of informed consent is, it's about providing information. What it doesn't do is it doesn't, as I said, change all the ethical parameters about all aspects of it. So it deals with the fact that various information needs to be given about various things, various contexts, but it doesn't address the fundamentals at member state level as to what needs to be provided in terms of, say, capacity questions. So when somebody has capacity to make a decision, for example, it doesn't address the age of a child to make consent and so on. So various of those issues, and they can vary between member states. So those are left to member states themselves to determine. So again, it's that sort of compromise issue of some things are addressed and which can be more easily addressed, actually, because they are almost a more formulaic issue if you're having an information sheet, or on the medical devices regulation, the requirement of providing information card rather than implantable devices, for example. Sort of warnings and risks on it. Those are things which are more easily addressed, if you like, at a general level. Other things are more discretionary questions which are left with member states.
All right, thank you very much, Professor Jean. So that's all I have for Q&A session. But before we end, I would like to give opportunity to Professor Monica, if she would like to add to today's session anything, or what are her views about the session. Dr. Monica, Professor Monica, if you could unmute yourself.
Thank you very much for this opportunity. I was not prepared for it. Anyway, I listened very carefully. I found this was really very, very detailed, very deep. As I'm not very healthy at this moment, I had some difficulties following it all. I want to say to Professor Jean a big thank you, and I'm very happy to actually have seen her for the first time. I've never seen you, but I have been reading your work.
Ditto. I'm delighted to meet you virtually as well, really.
Yeah, but don't look at me so much. I don't look as normal. I'm in a very heavy medical treatment at this moment.
Okay.
It's a very new experience for me. You know, all our colleagues in America and from Eleonora Brooks to Scott Greer, we all knew you, they all know me. So I'm very happy to have seen you. I noticed how strongly you finally put forward that this European Health Union is coming up. And although I didn't study this in detail, but I studied a little bit about all these COVID problems we had. And so I'm convinced of it. I saw some signs of it, but I'm very happy that you confirmed it, because you have been looking into it really on the European level with all the details. This is good news, political good news, scientifically good news. And I think for us Europeans, it's good news just as Europeans. One question came to me a little bit about this surrogate mothership that was asked from India, because they have a big market. So maybe it would be good to say a few words on which are the countries in Europe who do it and which are those who don't. And another issue about cigarettes, you brought it very much down to changing culture, but there's also lobbying and industry. I know, for instance, from Germany, they have a huge industry about the machines who make the cigarettes. And that's why they were so long before they followed the European Union. In France, who took leadership rather late on this topic, I've been living here for the last 45 years, so I've known all this gitane smoking and all this. Smoking was very cultural in France. For instance, the trade unions, they defended hard smoking and were very much against advertising for smoking, although it was most of the workers who died of this bad cancer. The other people smoked less. And they said it was absolutely essential to maintain smoking, the cigarette pause with the coffee, to maintain the solidarity of the trade unions. They meet at a coffee machine at 10 o'clock with a cigarette. So that was really cultural and badly understood. In other cases, it was very much industry and lobbying. But what these trade unions didn't know in France, or didn't want to know, was that the French state took a lot of taxes out of the smoking, although the money went off with caring for lung cancer later on in the health insurance, in the French health insurance. So maybe we have to tell our Indian friends, because they have huge industries and big health markets with a lot of lobbying, that we in Europe are fighting with this as well. And then the cultural issues like reproduction, for instance, I try to explain that in my own courses. That's really the heart of the cultural issues around health. And it will be difficult to bring the different countries together on that issue. But behind that also there are industrial or at least economic interests, because you have to pay for these things. So there's a lot to add. You had 2 hours. That was very short finally, although I found it long because I'm a bit tired. But we could talk so much more. And I think India is a good place to tell them, because they have these states and this federal system and this huge continent. It's very much similar in this way to Europe, and can be really good for them to learn a little bit of what we have already learned in terms of negotiation, diplomacy around health and so on. So I was very happy about your talk. It was very interesting. Thank you very much.
Thank you, Monica. Thank you. You had listened to it very, very patiently. So I wanted to give you an opportunity to talk about it. Thank you. So last but not the least, over to Stefano. Stefano, if you have a word or two to say about today's session.
Yes, hello. Can you see me?
Yes, we can. Yes.
So the only things that I want to say is thanks to Ashley Jean, and I want to say to Ashley Monica that you look very beautiful. And then I will just leave the floor to maybe Ashley Jean, as she have to answer to the question of Ashley Monica, and then I would just actually close the session. What do you think, Jean?
No, I'm fine really otherwise, but thank you very much for inviting me again, as I said, and I really appreciate the opportunity. And again, it's lovely to meet people, and again, like to connect again with yourself and also with Monica and Menikesh as well. It's lovely. Thank you, really.
Okay, thank you very much. We will be ending the session now for all the attendees. Thank you very much, Jean, for your expert talk with us.